So at the outset, I would like to thank Raju and Sekhar sir and the team Mastercase series for giving me the opportunity. And I think after the so many sports injury cases and soft tissue injuries, let's come to the basics, that is the fracture scenario. So I think this patient presented to us 33-year female about 4 months down the line. So I would like to have you seen these sort of cases, sir? Ever 4 months down the line, malunited like this?
Yeah, common in India.
boss लोग बोल रहे हैं. Yeah.
No.
Any experience on this?
I mean, no, the only time we see something like this, it's not traumatic. It's
Yeah.
you know, it's as in I've only ever seen this when someone's had a physeal injury, reverse slope, but this is intra-articular.
Yeah.
It's way worse than that. So
Yeah,
we very
so-
rarely see this.
So, Samir boss, appeal again. What should be the line of management in this sort of
So
case?
of course, I'll go further. You know, we need scanograms. We'll
Yeah.
get a CT scan.
Sure.
You know, at least to start with.
Yeah. So I think to give you, I have not put the scanogram. I do have the CT scan.
Dr.
So the
Sunit?
yeah.
Can we have the clinical picture before that?
Yeah, exactly.
What's the range of movement? What
Yeah,
kind
so-
of problem is patient having?
Exactly. So I have not put the clinical pictures were not there. So I have not put this. So I think the range of motion was full. There was a hyperextension of about 20 degree was there, and there was clinically varus was there. Also the patient walking with the varus. So actually this patient was referred to us to do some sort of ligamentous procedure because the patient's the hyperextension was there. The varus thrust was also there. So the doctor who referred it to us thought that some sort of ligamentous problem was there. The alignment was a little bit of varus. On the distal femur part is everything is okay. I think there was a gross varus around 20 degree and 20 degree hyperextension alignment view. And the CT scan this is the best possible thing. I think this you can see that the condyles are relatively larger, and the posteromedial condyle was on the reverse slope, and the lateral condyle was relatively better. I mean the slope was decreased, but not that significantly decreased compared to the medial side. There was difference of slope around 15 degree on the coronal view, sagittal view of the CT in different cuts on the lateral and medial.
I think
So,
2D
I mean-
images are more important in this.
Yeah, I do understand that 2D images are more important, but I think I'm giving you the 2D, I mean the things which you want to look at.
So
how
can
do
you just elaborate the anatomy that you're facing right now?
Yeah, I mean, so the medial side is the reverse slope of about maybe 10 to 12 degree of reverse slope. The lateral side is about neutral slope, that is about 0 degree. And there was a posteromedial fragment which is relatively bigger, and the lateral was relatively small. But the articular cartilage, two of them were relatively, two articular side is relatively intact.
And we don't have any deformity in the anterior aspect. It's
No,
mainly
and yeah, this is the posterior aspect, this is the anterior aspect. I mean, not much the deformity, the hyperextension was there because of probably the reversal of the slope, and the varus was also there because the medial side condyle was a little down. But clinically, I think the varus valgus stress was negative, the anteroposterior laxity was also not there.
okay.
So does MRI has a role now? Do
Yeah,
we
I
like to
think,
see
yeah,
the articular cartilage
Yeah,
before we plan anything?
Yes, of course, I mean, MRI do have. I mean, if you come across these sort of patient, I mean, if I have too much delayed, then the cartilage issue might also come in. So to have an opinion regarding the status of the cartilage, status of the meniscus, and of course the collateral. But I think these difficult scenarios, clinical test will give you much better idea regarding the ACL, PCL, and collaterals compared to your MRI. I think MRI you can sometimes it's a little difficult to interpret in these sort of situations.
Actually, arthritis was on my mind.
Yeah, but I think this was 4 months down the line. So I've been 33-year female, 4 months down the line, though not much of arthritic change is there. So I think that brings to my, I mean, the ARS questions. Yeah, you want to say something, Mark?
Did you say it was 4 months down the line from the injury?
Yes.
Did you have any imaging at the time of the injury?
No, I couldn't retrieve those
there's
images. That's not there. Yeah.
Can we have the first ARS question now?
So anyone who is opting for the D has to say why he has a better idea. Because I don't want anyone to be smarter than me. Oh, it's there?
So I would go with D.
Okay.
So any better ideas before we
Yeah.
proceed with the regular ones?
Who
So I would like to have a 3D reconstruction model for this to plan my osteotomy.
Yeah. I mean, but I think overall the planning is usually remains same. I mean, for the planning,
So
you
I
might
think it's
have a
another idea
feel.
rather than a better idea.
Yeah.
It's another idea.
Okay.
So, you know, for us, and I'm not sure if you can do this here, we would do a 3D reconstruction, but actually make it as well. So get like a 3D printer to actually
Yeah,
print
that's
the-
what he said.
the
Yeah,
full-
he's, yeah,
3D
Yes.
printing,
yeah,
yeah.
yeah.
So I think, Amashu, we can have a, so can you go back to the ARS response?
Yeah,
So HTO guys, can we just?
yeah, that's what.
have
The
hands-
42% of the
And
sales
Yeah,
are
so
sort of.
HTO.
Can we have all the options from the first question and then we can discuss one by one?
Mine was
And the
B.
answer actually is in his title of his talk, TCVO. We all know that. So it's written.
So-
The debate should be between HTO and TCVO. You know?
Yeah, exactly.
I think
And
we
why
are
so?
going,
The Sheetal has some point.
Just one point. This is not just a isolated slope of a media. Actually, if the medial tibial plateau, whole of the slope has gone. That was the reason for hyperextension.
Yeah.
Only one isolated tibial slope change will not lead to hyperextension.
No, no, I mean.
So the problem
yeah.
is dual here.
Yeah.
It's not only a virus,
Exactly.
it's more of a hyperextension with the reversal of slope. So you have to address both the things. Slope correction as well as virus correction.
Yes. So how would you like to
You
do
have
that?
address the problem and then you have to come for a solution.
So how would you like to, I mean, the real question is, would you like, since there was differential slope of the lateral and medial condyle, so would you like to do an intra-articular osteotomy of both the lateral and medial condyle and do the, I mean, exactly correction, slope correction, so that both gets corrected to roughly about 7 to 10 degree, or you want to do an HTO sort of thing to correct the medial slope mainly?
So I think
that's the-
HTO where we can correct both the slope, we can actually break one of the cortex and make it as a hinge, basically posterolateral hinge, and then cut your anterolateral cortex and then change the slope and do the valgus correction as well.
So anyone else, Raghuveer sir, you do a lot of, Raghuveer sir is there, sir, you do a lot of TCVO. So what's your opinion in this sort of situations?
So it is only the, what Sheetal was saying, correct both varus and slope.
Yeah, but I'm talking about the differential slope. So the hyperextension was there on lateral condyle as well, but the medial condyle went into far more hyperextension compared to the lateral condyle, because the lateral side the slope was 0 degree.
You are using a TCO because we are doing only medial tibial condyle correction. So when you are doing the correction, you put the graft, so that graft is wider anteriorly,
Okay.
so that
So-
it can reverse the slope and same time you do the virus correction.
Okay.
So Sunit sir, if
So it
I'm
is a
getting it
combination
right,
of both metaphysis and intra-articular.
so if I'm getting it right, you are asking whether we should correct both the lateral side and the medial side slope.
Yeah, separately or not?
While with one osteotomy,
Yes.
and which is still not decided.
Yeah, no,
where
I
to be
mean,
done.
with one osteotomy, it's very difficult to control the slope of that, which differs so significantly. What
So
is
if
your
we
opinion, Raghuveer, sir?
go reasonably in our expectation and we just correct what is there on the medial side, probably the patient will have good function.
Yeah.
So my opinion is these are challenging, obviously, cases that's stating the obvious, but I don't think you can correct both of the slopes at the same time and expect that you're going to get a neutralization, because what will happen is you'll massively increase the lateral slope
Yeah, exactly.
and neutralize the medial slope. So you either manage them independently, which I don't recommend, or, and I think Raghuveer is alluding to this, you can independently do the medial slope and correct the varus correction at the same time, either through the single osteotomy or do an osteotomy below it. But I agree with what you're saying, sir. I think, the recurvatum is coming from both the medial and lateral
Yeah.
side. But
So
what you want to achieve for this one is a neutral slope on both the medial and lateral side. And if you can just do that with the medial plateau to neutral, I think she'll be much better off.
Okay, let's see what you have done.
Yeah. So we did actually intra-articular osteotomy both separately lateral and medial, and this is the lateral side, and you can see that this is after doing the lateral release. I think this is the lateral condyle, and there was a medial side slope correction as well. We tried to recreate the fracture line and then did the separate, and this is how the Siam view looks like postoperatively. So both the condyles were slope correction were done separately. On the medial side, after correction of the varus, the significant void was there, so iliacrus bone grafting was there, was also done. So I think the only big problem is this much of patella baja after correction of slope, because this was quite significantly hyperextension. This was there But I think the real worry with this patella baha was probably range of motion establishment. So we allowed the early range of motion to this. Any opinion about this? Is it until then it's look okay? Yeah. So I think this is the post-operatively X-ray, and this is about 4 months down the line. And this is the patella baha. That was the real concern. So I learned it today that we can lengthen this ligament of patella as well. So I might offer that patient. But the good thing is patient reasonably have a good range of
Sunit,
motion.
1 minute. I just wanted to know your sequence of correction. How you went?
Yeah. So I think in majority of the intra-articular correction, I usually do the medial side first. So I try to through the posteromedial exposure, we try to recreate the fracture on the medial condyle first, and we try to go from below upwards. So try to locate exactly where the malunion was, and then do the saw bit there, and then try to go as proximal as possible. And just before completion of the intra-articular side on medial side, then we went in the lateral side as well, expose it thoroughly, and try to locate exactly the fracture lines which are there on the intra-articular part, and then try to create the lateral side also, then control the both the slope with the two sand spins put on the both the condyles, and try to match the jigsaw as much as possible. Then once you do the matching the jigsaw, fix it temporarily with the K-wires, and then after that putting the hardwoods, it's not a big deal.
So Dr. Sunit, if I understand it well, it's a little bit complex. So medial side, you did a L-shaped osteotomy. You did a raise from the
not exactly that TCVO type of L-shaped osteotomy. It was more on
you just
the lateral
went
side.
through the fracture line, and
exactly.
did the osteotomy only in one plane.
Yeah.
But we can see that there is a L. Can you go back to the
X-ray? More
X-ray?
of a L-shaped rather than this side.
Can you go back to the previous X-ray, please? Previous X-ray. Can you see what is that vertical?
This one.
Yeah, this one.
This one is the lateral one.
Oh, that's for the lateral one.
Yeah.
For the.
Yeah, more of a bicondylar osteotomy. Yeah.
So the lateral side is opened in form of L.
Yeah.
Okay.
So I think the patient is actually this much of range of patient is happy actually. Patient's or the ligamentous problem has gone, no instability. She is walking well, and she is actually not willing to do anything for her. I don't think we need to address the patella at this stage as well, because the patient is happy with this 110 degree of range of motion, no FFD. The hyperextension is also gone. So I think she is happy right now.
You have done a bicondylar fracture.
Yeah. So yeah, exactly. Yeah, it's not exactly a TCVO, you can call it. Yeah. Yeah. So I think my takeaway from this case is probably not all instabilities are ligamentous. If you have the bony problem, then probably that might also be the cause of the instability. Significant malunion.
Just one query.
Yeah.
It was excellently done. So, just one suggestion. I don't know I'm right or wrong. So, how about going like a midline incision, doing a TTO, completely taking off the tibial tuberosity and addressing both in a single incision, as well as that would, once you place back, the Baha portion also would be corrected.
Yeah, exactly. Okay. I mean, the Baha portion you want to. Yeah.
So once you take the tibial tuberosity up and then you place it back, the whatever position what you have done, the slope correction and the varus correction, and once it goes back and then it nicely sits there.
Yeah, that might be an option, but I think the patella alta was not my concern in initial part. I never thought that patella alta is going to the problem postoperatively. It's only after correction of everything we landed up that patella, the Baha was there. So I think I never, pre-imagined this problem preoperatively. I was more concerned getting the exactly the slopes corrections which were there. So, but at the end we landed up there. But I think it's if you do after 2 bicondylar osteotomy along with 1 tibial tubercle osteotomy, I think the chances of failure of that tibial tubercle fixation is maybe a little more higher. So I didn't venture on that, but that might be an option.
And implant placement is quite easy with 2 incisions, I suppose.
Yeah, exactly.
Excellent case, Dr. Sunit.